Dear members of AAPI, thanks for being here again. And we have a distinguished panel of speakers from Boston, Harvard. We have Dr. Katwa, who's going to be the moderator-in-chief here. I'm just assisting him. And we have other speakers from the same institution. I'll let Dr. Katwa take over from now to introduce the speakers. And we will put our numbers on the chat box. If you want to text a question, you can text to me and Dr. Katwa. And you can also use the chat box or question and answer box at the bottom of the screen. There are different ways you can communicate to us. And go ahead, Dr. Katwa.
Thank you, Dr. Ravi. So good evening, everybody, and thank you so much for coming over here. I know people are getting a little bit fatigued with the COVID information. We're not going to bore you more, but we're going to be quick, crisp, and out. So tonight, I decided that I will have my colleagues who I work very closely with to talk as a group, as our experience and what we learned from the COVID over the last 3 months. So for the first, I will start with a brief clinical presentation, and I will introduce each speaker at the beginning of their presentation. So I'm going to start with my screen share. Can you see this?
Yes.
Okay, and slideshow. Okay, so I will be talking on a clinical presentation. I will briefly discuss some of the data from China, Italy, and US. So without going into much of the basic pathophysiology, I think we know enough of this for the last, and I think we can just wake up and dream and talk about this. But just to go over quickly, COVID-19 or SARS-CoV-2 is a zoonotic spillover disease, and there is a debate about did it come directly from bat to humans or is there an intermediate host? It's up for grab. After that, there has been a rapid human-to-human transmission after the first initial cases identified in a wet market in Wuhan. And as we know, it is a highly contagious virus. As we learned in our medical school, it's an epidemiology triad. There has to be an agent and a host, a susceptible host, and a right environment. Obviously, the vector play a role depending on from direct transfer from a vector to the host. So, and then virus targets your epithelial cells predominantly, which is the main source of entry, which is predominantly seen in nasal epithelium, in the bronchial epithelium, and in the lungs. It binds to an angiotensin converting enzyme receptor. From there, it can go into the blood vessels, causing viremia and subsequently to other organs. Increased expression of the ACE2 receptors known to facilitate COVID infections, and genetic polymorphism, which determines how much ACE2 receptors you exhibit can determine your resistance to this virus or extreme susceptibility and severe disease. Particularly in children, these are some of the common risk factors we have noticed. Unlike in adults, obesity is predominantly one of the major risk factors in teenagers and young children as likely to have severe disease. Children with chronic lung disease, asthma up in air. We have seen some children with asthma, but it is not as much as we thought initially. Cystic fibrosis, we have seen a very few patients with cystic fibrosis and primary ciliary dyskinesia for some reason we clearly don't understand. Hypertension, immune deficiency is predominantly one of the common cause of having severe COVID requiring hospitalization, and patients on chemotherapy, cancer chemotherapy, particularly infants less than 1 year at high risk. So how does this disease present in pediatrics? A lot of people say a lot of children are asymptomatic, but some have debated that they could be pre-symptomatic. That means you caught them at an earlier age. But nevertheless, children tend to have such a mild disease in many of them that it may be passed as a common cold. Some children even present at atypical symptoms, predominantly like GI symptoms. The mean incubation period in children is about 5 days, can vary from 1 day to 14 days. There can be multisystem involvement, but the presentation can differ from patient to patient. Predominantly, the symptoms are respiratory in pediatrics. The most common symptoms are cough. Initially can be dry, but later on, there can be a secondary bacterial infection, can have a wet cough. Fever, which is persistent, which is a pretty common symptoms, and myalgia. These symptoms compared to adults are less common in children. So you can't define just fever and cough as the diagnostic symptoms of COVID in pediatrics because these are not commonly seen as in adults. The other common symptoms are running nose, slightly more common in children than in adults, shortness of breath, rapid breathing, Hypoxia. Children can be hypoxic into their 80s and sometimes in 70s without overt cyanosis or any other symptoms other than just some shortness of breath or tachypnea. They can develop pneumonia symptoms, can rapidly progress to ARDS, and ultimately respiratory failure. So now coming to the other system. So recently a huge meta-analysis found that about 17% of the children can have GI symptoms. Most common are diarrhea, anorexia, vomiting, and nausea. They can also present with abdominal pain and sometimes dehydration. Loss of smell is seen in older children, but again, children are not very good historians, so you may not experience these symptoms in pediatrics, but nevertheless, in older children, you can experience that or they may complain that. Altered mental status can be because of hypoxia itself or because of encephalitis-like picture because of the viremia. Seizures can happen because of hypoxia, also thrombosis, or because of an encephalitis-like picture. They can be delirious or they can be generalized weakness. From a cardiac perspective, again, depending on what kind of presentation, if it's a multisystem, cytokine, storm-like presentation, they can have a host of cardiac problems, of arrhythmias, myocarditis, bradycardia, cardiac arrest, and heart failure. Unlike in children who present with multisystem inflammatory syndrome, which we're going to talk in the next few talks, they can also have a significant cardiac involvement, predominantly present in like Kawasaki-like disease. Other symptoms, we talked about rash, kidney failure, sepsis, anemia, coagulopathy, and liver failure, which we typically see in adults, can also be seen and reported in pediatrics. Some atypical symptoms like COVID toes, we have some case reports seen in teenagers. Unlike in younger children, we see less of this, but more so in teenagers, but also some of the children present with atypical rash, viral rash. This can be very painful because of some clot or peripheral coagulopathy supplying the toes. COVID eyes, like conjunctivitis-like picture, has been reported, and there are viral RNA particles identified in the conjunctival fluid. How does the immune system respond or change with the disease progression? So initially after incubation, a median days of 5.1, typically in the respiratory epithelium, the SARS-CoV virus replicates, and at that time there can be some mild runny nose or snuffles-like symptoms. Typically there is no fever. At this time, there can be some viral shedding at this asymptomatic phase. And as the patient goes into mild to moderate phase, which is about 5 to 10 days, the viremia count increases, and also there is high viral load in the epithelium. The epithelial damage happens and breaks the barrier and enters into the bloodstream, and there is recruitment of neutrophils and other inflammatory cells, releasing TNF-alpha, IL-6, and other IL-10, and then you can have symptoms of fever, cough, fatigue, and myalgia. And initially, the lymphocytes count start dropping down slowly. It is not severely leukopenic at this time, but some people, instead of getting cleared at this stage, may enter into this cytokine storm. And this is like too much of too late. So much of cytokines lead to significant persistent fever, significant organ damage, rapid increase in interleukin-6, and drop in your lymphocyte count. So again, depending on your presentation, at what point in time you clear the viruses, most of the children have a very robust innate immune system. They tend to clear the virus at this stage. They're very, very effective. They have a very effective immune response, which is typically innate immunity. And they have a very defective adaptive immunity. So most of the kids don't go into this cytokine storm stage. So either they end up mild or moderate at the most. So some patients may progress to severe critical disease, like severe progression. About 5% of the children become rapid respiratory progression. You can see the X-ray whitening out over a period of time, becoming very hypoxic. If you do the CT scan, you can see initially some nodular round opacification, increasing much more bigger, causing pneumonias. It can be in multiple locations, typically located at the bases, at the lower lobes. So there are some extreme phenotypes. In children, it can be silent hypoxia. Children can be extremely hypoxic without a significant change in the lung compliance, can become severely hypoxic, and they can be asymptomatic for a long period of time. They also develop this multisystem inflammatory syndrome, which we're going to discuss later, presenting either like septic shock-like presentation or Kawasaki-like disease, and ultimately your cytokine storm in some of the severe cases. So this is a meta-analysis mostly of the Chinese data, predominantly consisting of 38 studies, including case reports and series, including from Chinese CDC. They analyzed about 117 patients whom
there was a report of classification of severity, including 1 death. So if you look at this, about 36 and 46, about 82% of the patients can be predominantly in the mild to moderate category. About 2.3% of the children can be in the severe to critical category. The most common symptoms in pediatrics: fever in about half of the patients, cough in about 41% of the patients, and pneumonia-like picture in about 1/3. So these patients can have a milder symptoms, atypical symptoms, and cough and fever is not seen in all the patients with COVID-19 in pediatrics. This is the data from Italian cohort, about 130 children from 28 centers, about 10 regions of Italy. They had slightly higher percentage of critical presentations, about 6.9%. Predominantly, most were again asymptomatic or mild presentations. And you can decide or divide patients into asymptomatic phase when they have no symptoms and sign. You do contact tracing and you test the family members and you test the children, and they are positive, but there are no symptoms. X-rays are negative. Then typically you have mild patients without very mild URI symptoms, then patients with moderate symptoms. Severe, they tend to have desaturations up to 92% or below that. And patients who are critical are the ones with the progressive respiratory symptoms, ARDS, and multi-organ dysfunction. And the report from the American CDC, up until April 2nd, 2020, they analyzed about 240 cases at that point in time with about 5,000 plus deaths. About 150 all-age lab confirmed cases are analyzed, and only 1.7% of those lab analyzed cases were children less than 18. As we know, the US population has about 22% of the children under the age of 18 years. So there is a significant less representation of the COVID population. About 3 deaths were reported at that point in time when they analyzed the data. Again, when they analyze the symptoms, you clearly see that in adults, predominantly fever, cough, and shortness of breath were the most common symptoms, almost 93%, compared to children's is about 73%. So symptoms are similar, but they are less frequent and milder. So the burden of COVID-19 among children in the US is about 2%, in China about 2.2%, and Spain only 0.8% of the children had COVID symptoms. COVID in newborn and infants, again, typically the newborn baby gets COVID either by an infected mother or a caregiver. So far, there is no clear evidence of vertical transmission or a transplacental transmission. These kids are especially at high risk of hospitalization and developing severe disease. They can initially develop a pneumonia and atelectasis, or sometimes the chest X-ray may not look as bad as initially, and there can be some degree of hyperinflation. So a lot of newborns can also remain asymptomatic, and they can also shed the virus from their saliva and the nasal secretions. So when you're dealing with an infant, you really have to take all these precautions. So it can also lead to respiratory distress, severe hypoxia, multi-organ dysfunction, and there are several infant deaths reported in the US. So when you compare between adults and pediatric COVID, so the adult COVID is more likely to be symptomatic, whereas pediatric COVID are more likely to be asymptomatic. Most common symptoms are fever and cough, about 90+% of the patients. Even though these are more common, they are less common than adults. About 20% tend to be severe compared to only 10% in pediatrics. About 10% get hospitalized, about less than 5% get hospitalized. And overall death rate this is kept on changing, about 1 to 2%. In pediatrics, the deaths are extremely, extremely rare unless there is something underlying condition. The death rate in the ICU or ventilated patients is about 50 to 80% in adults. In pediatrics is about 4 to 5%. And again, we have seen patients who are intubated recover very dramatically. Again, most of the patients can present with atypical symptoms, and the diagnosis sometimes because of this presentation can be challenging. So and the question is, why do children tend to get less severe COVID-19? So one, we have to know that the children are at the same risk as adults of getting infected. But I think there are several epidemiological factors which is underestimated that they played a significant role in less cases in children, which is the early closure of schools, daycare camps, which helps to reduce the exposure. Most of the adults go to work or they're in contact with people, they get infected. But once this was closed, the kids were at home, so there was not much cross infections. The kids who got infected were the one from adults bringing home and then cross infecting. The immunological factors, like they have a better innate immunity, better clearance of virus at the site of entry, lower viral replication and lesser viral load, and less cytokine storming and cross immunity from other coronaviruses. Lung factors, They have less ACE expression in their epithelial cells, so they have less entry points. And as we know, the pediatric lung has an excellent regeneration capacity. We have seen patients with severe necrotizing pneumonia, and within a few years, the lung is absolutely normal. So they have a great regeneration capacity, and they have a lesser degree of inflammatory malaise overall. So they have a lesser degree of obesity, COPD, diabetes, and age-related changes in atherosclerosis, which are major risk factors in adults. So I think last couple of slides, what are the key principles in management in pediatrics COVID? One, you need to reassure the parents and the child, which is extremely important. People are very anxious with this disease. You need to be vigilant that some patients can develop complications, so you need to watch them. Don't just assume that they all have mild diseases. Please involve parents and communicate very clearly, because there are a lot of anxiety. A PPE wound, like a doctor in front of the child, can cause a lot of anxiety and scaring, so you need to be very friendly. And teamwork, and once you have a patient, absolutely you have to work with your colleagues to treat these patients. And in summary, the pediatric COVID patterns are less clear as fewer children are affected. Nevertheless, severe disease is known, so you should not assume that everybody will be mild. You should watch them very carefully, particularly who are obese, older kids, or infants, or underlying comorbid conditions. And then differences in children compared to adults provide a key insight and may shed light into some of the immune modulated therapies which we can develop. And population measures directed towards social distancing, including school closures, masks, appears to be important in slowing the spread of the COVID-19 in children. Thank you.
That was a great summary, Dr. Katwa. And just kidding, the pediatric physicians, your PPEs have a lot of polka dots and animals on it?
Yeah, I think if you really look at that one, that's a small step in making things kids-friendly.
Right.
Also, they are coming up with the mask, which are smaller size, because most of the, if you give the same mask which you use for the adults, for the kids, sometimes it just closes whole their face. So having the size, printed Disney characters or whatever, like homemade mask, if you use something which is their favorite character, is pretty awesome.
Great. All right.
So I think moving forward with the next talk, I invite Dr. Tanvi Sharma. Dr. Tanvi Sharma is my friend and a colleague here at Boston Children's Hospital. She is Associate Chief and Clinical Director within the Division of Pediatric ID and serves the Director of the Pediatric ID Fellowship Program at Boston Children's. She is the co-director for Infectious Disease Pediatric Transplant Center at Boston Children's and assistant professor at Harvard Medical School. Actually, she has played a huge role in our institute during this crisis and has served on the PCH Pediatric COVID Crisis Recovery and Reentry Task Force. She has played a significant role in developing protocols, treatment protocols, both locally, nationally, and regionally. Tanvi.
Thank you, everyone. Thank you so much for having me this evening. I'm just going to spend a little bit of time talking about some of the diagnostic and treatment challenges that we deal with in children with COVID-19. So first, I'll just provide some objectives. I'll talk a little bit about the diagnostic strategies and the testing methods that we use for SARS-CoV-2 infection. And there's been a lot of discussion already that many of you are well aware of about the testing strategy. So one of the things I'm going to try to focus on is serologic testing, which is something that many people have questions about increasingly as we're moving forward with this pandemic. I will also talk a little bit about the treatment challenges that we experience with pediatric patients and talk through sort of a framework for treatment considerations in which patients should be considered for treatment. And then I'll summarize some of the potential therapies that we have for COVID-19 and their use in children. So just in terms of general testing for pediatric COVID-19. So first of all, the general principles are that really the testing recommendations by the CDC really align with what the strategies are for adults who have suspected SARS-CoV-2 infection. So there, as we know, as Dr. Katwa described, there's really a limited burden of infection in children. So not only do we have to think about SARS-CoV-2 diagnosis, but we also have to think about the other differential diagnoses that should be considered in our children who have respiratory viral symptoms or other symptoms as part of this pandemic. And one of the things that we have seen is that with this pandemic, there's been so much focus on COVID-19 itself and diagnosing COVID that it's sometimes been at the expense of working children up for other causes of these similar symptoms. There are some specific considerations for testing of newborn infants. So as Dr. Katwa just described, there's sort of a unique entity of newborn infections, and I'll talk a little bit about how we deal with newborns who are infected, who are born to infected mothers. And then there are both clinical criteria and virus-specific criteria that are used for testing and making a diagnosis when we're thinking about multisystem inflammatory syndrome in children, which I will let Dr. Lee talk about a little bit later in this evening's program. So let's talk a little bit about kind of direct viral testing. So nucleic acid tests or PCR tests are what we use to detect the SARS-CoV-2 virus RNA and is really the mainstay of diagnosing acute infection. We use the same assessments and approach to testing as we use in adults, which is primarily nasopharyngeal testing, but oropharyngeal testing and mid-turbinate swabs are also acceptable sample types. Testing is really recommended, of course, for patients who have clinical symptoms, but also for children, asymptomatic children who have a positive close contact are also recommended for testing. Antigen testing and point of care tests are also becoming increasingly widely available. So these are sort of immediate tests that you would do in a primary care practice or an office practice. And the challenge with these tests is that they have variable sensitivity. So it's really important to ensure that any commercial test that is used is approved through the FDA Expanded Use Access Authorization Program, which has gone through some rigorous testing to assess the sensitivity of the test. And there are a number of tests out there that are approved and a number that are not yet. So the challenge with thinking about direct viral testing, so first of all, PCR testing is highly sensitive and specific. And there have been some questions and concerns early on with early studies suggesting that repeated testing was necessary to increase the sensitivity of PCR. However, these studies really haven't been replicated. And what has been shown over time is that it's actually likely not the PCR where there is a concern about sensitivity, the PCR assay itself, but really more of things like the specimen collection technique. So whether a sample is actually a nasopharyngeal sample versus just a nasal swab, which will give you lower yield than a proper nasopharyngeal sample. Whether you are testing a patient further on after development of symptoms, so 5, 7, 8 days into symptoms, the viral shedding goes down dramatically and you'll have lower sensitivity of the PCR test because there will just be less virus there to detect. When we're thinking about serologic tests, which has really become sort of the big question and something that we're getting asked about all the time, is how do we use these tests and what are the criteria that we're implementing to think about where serologic tests could be useful, particularly for children. So as you can see from the schematic, early on, before symptom onset, when you have SARS-CoV-2 exposure is really when you see a dramatic increase in the viral load, particularly in nasopharyngeal swab testing, but also in other respiratory sample types, and then a little bit later on in stool. A week or two after symptoms develop is when you start to see increasing development of antibodies, both IgM and IgG. And what's unique about this virus is that the kinetics of antibody development seem to be very different from some of the other viruses that we think about, where you expect to see an initial rise in IgM and then later on a rise in IgG. With this virus, it appears that the antibodies develop actually almost simultaneously or maybe just about a week apart. So it's often difficult to assess whether a person has more acute infection or recent infection versus a more remote infection just on the basis of antibody testing with IgM and IgG. So the serologic tests that we use for antibody detection are detecting presence of the antibody against the SARS-CoV-2 nucleocapsid or the spike protein, and some tests include both detection of both protein types. Some of the initial studies that have been done show that the median time to detection of IgM is about 5 days after symptom onset and IgG about 14 days after symptom onset. But as I mentioned, there can be some overlap. And this is compared with PCR, which is really most sensitive within the first 5 days of symptom onset. So by the time you start to see antibody rise, you would expect that many times PCR testing would be negative. And as I mentioned, the kinetics of antibody positivity vary. And in some studies, there's even been the demonstration of IgG antibody being developed prior to the presence of IgM. There are a large number of commercially available antibody tests, but only some are authorized through the FDA expanded use authorization process. So again, this is an area where it's really important to know the type of test that is available and what the sensitivity and specificity, as well as the FDA approval process is for that particular test. So there are some limitations that are really important to consider with antibody testing. So first of all, with positive results, it can of course indicate recent or past infection because of the kinetics of the IgM and the IgG. So it doesn't really exclude patients who have been recently infected who may actually still be contagious. So we do see, because of the timing of the rise in antibody, we may see continued PCR positivity as well and viral shedding, which means that a person can actually transmit virus. The degree and duration of protective immunity is really unknown. So we don't know whether this antibody is actually detecting neutralizing antibody that actually will confer immunity. And then we don't know how long this antibody will last in patients who've been infected. So some of the previous studies that have been done with the 2005 SARS outbreak demonstrated that there was a reduction of antibody titers by about 50% within the first 2 years of the infection, and then by about 75% within 3 years of infection. So we don't know if the same will occur with this virus, but there are of course, some suggestion that that may be the case and that there may not be durable protective immunity, even if the immunity is actually protective. And then there are some antibody tests that have been studied where there has been cross-reactivity reported with some of the endemic coronaviruses that are circulating naturally in the community, particularly antibody tests that are targeting the spike protein, or in patients who get IgM testing alone. And there can be false positives with testing if there is this kind of cross-reactivity. So one of the main necessities for assessing antibody tests is ensuring that this cross-reactivity is not occurring. And then there are also some limitations of negative results. So patients with mild infection may actually have a false negative antibody test. They may not make antibodies at all, or they may develop antibodies that are below the limit of detection for the assay. Additionally, a negative serologic test doesn't really rule out COVID-19 exposure or infection. And then some of the studies that have been done where antibody testing has been done very early on that can yield negative findings, and we may not actually have seroconversion yet in those patients. So it's important to assess what the timing is of antibody testing. Additionally, as I mentioned, titers may decline and eventually become negative. And it seems like the sensitivity of total antibody tests, where there is a combined assessment of IgM and IgG together, seems to have some degree of higher sensitivity than separate IgM and IgG tests. So this is an important consideration for the type of antibody test that is being used. And at our hospital, we actually use the total antibody test to provide greater sensitivity. So really, when do we think about using antibody testing? Well, first of all, it's used epidemiologically and for contact and exposure reasons to assess if patients who are presenting several days after symptom onset or without symptoms was actually in fact exposed to the virus and may have been infected. But of course, the limitations that I mentioned have to be considered. And then it can be used in children specifically for diagnosing multisystem inflammatory syndrome, which generally occurs later in their course. And at that point in time, they may not have a positive PCR any longer. So the antibody testing can be useful in this circumstance. So just to summarize, serologic testing is really just an attempt to assess if somebody's had COVID-19, but really shouldn't be used for any kind of clinical decision-making or reassurance. It shouldn't be used as the sole basis for diagnosing COVID-19 infection. And it's important to know that there are a number of serologic assays that have already been developed and that are out there, but there are limitations of both false positive and false negative results. But SARS-CoV-2 serology does really hold promise over time. And as we learn more about it, it's going to be much more useful potentially for our patient population. I just want to quickly mention infants. So transmission of SARS-CoV-2 does occur from mother to child or from caregivers to infants. And just in terms of testing for these babies, if they're exposed, the CDC recommends testing all neonates for COVID-19 if they're born to a mom with confirmed or suspected infection, regardless of whether there are any signs of infection in the neonate. And infants who do have any symptoms at birth should undergo evaluation for other etiologies as well, because most commonly this infection is transmitted postnatally, so you wouldn't expect a baby to have any symptoms at birth. PCR testing should be obtained at 24 hours of age and then repeated at 48 hours of age if the initial test is negative per the CDC recommendations for infants. And this is a population in which we would not recommend using serologic testing because there's the potential for false positives if mom has developed antibody already, and that can be transmitted to the baby. Okay, so I'm going to switch gears quickly and just talk about treatment, and this will be relatively brief. So there are a number of challenges in thinking about treatment for children. So first of all, as you know, there are no FDA-approved therapies, and all of the existing candidates are experimental or repurposed for other indications. And really, there's extremely limited literature overall regarding safety and efficacy, although this is rapidly emerging and evolving, and much of the data is really in adults. Obviously, clinical trials are optimal and they exist in adults for some of the therapies, but are limited in pediatrics. The core questions we think about in pediatrics with regard to treatment is it even indicated at all? As Dr. Katwa was describing, pediatric disease is quite rare, and so we may not need to consider treatment in the vast majority of children, particularly in the outpatient setting and outside of the ICU. What criteria should define the population for whom treatment should be considered? And should there be a different threshold for children with underlying conditions? And what are the optimal choices if we were to opt for therapy? So as has been mentioned, most children have mild disease and really only require supportive care. A lot of the therapies that exist have potential significant toxicities, and the potential risks of treatment may outweigh the benefit in the absence of efficacy data for most children. But there are rare cases of severe and critical disease, and in these situations, the risks of therapy may be justified. And again, with multisystem inflammatory syndrome, as we'll hear, there are additional treatment strategies and incorporation of immunomodulators that may also need to be considered. So when we're thinking about the severity criteria, they're listed here. These are the same severity classifications that we consider in adults with COVID-19 infection as well. And with children specifically, we would consider those who have severe disease or critical disease as the candidates where therapy may be warranted. And so the therapeutic candidates that we think about, of course, are antivirals. So remdesivir is the one that we've heard about the most. There are multiple adult trials ongoing. There is now a new pediatric trial that has been initiated, and it was available for pediatric patients in a compassionate use basis initially, and now through an FDA expanded use authorization. There are some limited but existing safety data from some of the earlier trials where this drug was used for Ebola, and there are some promising early randomized controlled trial data from adults. Hydroxychloroquine got a lot of press early on because of its possible efficacy in vitro studies and some limited clinical data. And of course, it's been extensively used for treatment of malaria and rheumatologic conditions. But really more of the recent data with this drug is that really there's no clear benefit in viral clearance or clinical recovery, and that there are increased cardiac effects. So it's really no longer recommended, and we don't use it typically for treatment except in specific circumstances. There are adjunctive therapies, so immunomodulators that are used in various circumstances for severely ill children, and convalescent plasma is also being used. There's a national expanded access program for adults, and then some clinical trials that are being initiated in adults and children. And then finally in development are, of course, monoclonal antibodies and vaccines, which is, I think, going to be sort of the wave of the future for this infection. So just to summarize, in terms of testing, the optimal timing and the role of direct viral tests versus antibody detection is evolving and maybe a little bit more complex in pediatric patients. With regard to neonates, there are special considerations for testing that we need to be mindful of in terms of children who are born to COVID-infected mothers. And then with children who do have COVID-19 infection, treatment is generally not required, but studies are ongoing, and so we may learn more over time about the new therapies that may be possible in children. Thank you all.
Thank you, Tanvi, so much. We'll move on to the next talk, and people just text me or put the questions in the message center. We can definitely answer those towards the end of the presentation. So I will invite Dr. Lee. Dr. Lee is my colleague here at Boston Children's Hospital. I know him since his residency days, so we've been here for some time now. So he joined as a faculty in 2016. He's an assistant professor of pediatrics at Harvard Medical School. He's a physician scientist, and research interests include myeloid cell biology and autoinflammatory syndromes. He's studying the overlap MIS-C associated with COVID-19 and other inflammatory conditions, including Kawasaki disease and macrophage activation syndrome. So Dr. Lee.
Thank you, Dr. Kawa, for the invitation. And also thanks for Dr. Sharma for mentioning this condition already. So give us sort of a nice way to introduce this condition. So we'll talk a little bit about multisystem inflammatory syndrome in children today associated with COVID-19. And I will say that this is really a new condition that we're just all learning about, right? So the official nomenclature just came 6 weeks ago. So this is sort of learning as we go. Nothing to disclose. So objective of the next 15 minutes will be just give you an overview of what MIS-C is about. To tell you a little bit about our experience with the 28 patients we've seen so far in Boston Children's. And I'll compare a little bit about this condition with some known all-inflammatory type syndromes, including Kawasaki disease and macrophage activation syndrome. Some of these you've heard a lot about in the news recently. So it's nice to have the introduction to what COVID-19 is in children already. So we started this with the stories from China, looking at the data there where the majority of children have fairly mild infection, right? We really did not have a ton of morbidity or mortality. The story for MIS-C really started in Europe with a couple of series started in Italy and followed by the ones from London. And then subsequently spread to New York and then to Philadelphia, to Boston. So now it's really going across the United States. In Bergamo, Italy, that what was reported in as early as April even was that there is a lot more Kawasaki cases in this region. They rarely see Kawasaki disease there. They said there, and on average, in typical April, they would see 1 or 2 cases, and all of a sudden they had about 10 cases there. 5 of these kids were also had syndrome of shock, and many have high ferritin levels. In Kawasaki disease, typically we treat IVIG unless things are really severe. Then we do steroids also, and 80% of those children got steroids. 2 of them had aneurysms that look very much like the classic Kawasaki disease. And by testing, the majority had antibodies to COVID-19 and SARS-CoV-2, and very few had a positive PCR positivity. So they thought this was somewhat of a more severe form of Kawasaki disease. It's a type of sort of a new syndrome brought out by the virus. Then came a story from London, or in the study of the ICU there, where they all of a sudden got a wave of children with very sick sort of cardiac illness. Many of them were intubated, many required pressors for hypotension and ventricular dysfunction. 1 needed ECMO that ultimately passed away. And in contrast to the Italy story, that most of these are also SARS-CoV-2 testing negative. Now it's also by PCR, and I didn't include much of the serum studies at that point. So from that series, they concluded that it causes a severe cardiac illness. So with this information, also additional data from both London and also from New York, the major organizations in the world came together and put out this public advisory about this potential syndrome in children. In Europe, they call it Pediatric Inflammatory Multisystem children, temporarily associated with COVID-19. And in the CDC and also by the WHO, they call it Multisystem Inflammatory Syndrome associated in children. It's called MIS-C. So I'll show you the definition for the CDC definition here. So they define it as this condition, any individual under 21 years of age with fever, laboratory medicines of inflammation of any type, and must require hospitalization, have to have the two different systems involved at least. So these are cardiac system, renal, respiratory, hematologic, gastrointestinal, dermatologic, and neurologic, which is a sort of everything, right? You have to have at least 2 systems. Cannot have an alternative diagnosis. This is really important, because along the way, we have found many other kids with different types of infections, including urinary tract infections, other respiratory viruses that sort of give somewhat of a mimic to this syndrome because it can easily cause multi-system effects. So in terms of testing for SARS-CoV-2, you can be positive for PCR, could be positive for serology antibodies, or you can have just exposure for the prior 4 weeks, a known exposure, right, without any of these positives tests, just to catch some of these kids where their PCR is negative and they're not yet developed the amount of antibody that you picked up in the serum studies. In the CDC definition, you have to have fever for at least 1 day. In the WHO definition, it's fever for 3 days. And they have a couple of other sort of asterisks down here to say you have Kawasaki disease and fit the criteria that also belongs to this category of MIS-C. So all of this was established around mid-May. And then since then, you can start looking at PubMed now. There's a whole wave of literature on this condition now. So many of these are now coming from the United States, from New York and France and other places. So next, I will talk a little bit about experience in Massachusetts, specific Boston Children's Hospital, where early on, we're one of the hardest hit states in the US. This is summarized toward the end of May, where we had more than 100,000 cases total with 7,000 deaths. And as far as we know, community spread of this condition started around early March in our states. So down here on the plot down here, it's looking at the number of new cases each week, plotted from March to May, the end of May, and look at the different age groups. So it is true that overall, right, and for the whole population, the peak for this condition, for infection, came around late April. So by April 26th, that week had the most infections, and we had a steady decline since then. What is different is the pediatric group. So age 0 to 19, you can see this is the orange line. The peak is much more delayed, right? We didn't actually hit the peak until toward the end of May, and now we're starting to come down. So there's a delayed trajectory of the pediatric cases, which would represent about 5% of reported cases in the state. And this coincides with the MIS.C cases that we're seeing in our hospital as well. So far, I think we're seeing about 30 cases. Toward the end of May, we had about 28. So part of this is coinciding with the definition, right? So we had the definition for this condition towards the middle of May. So this is why perhaps we saw more of that around that time. But if you retrospectively apply the definition to some of the patients we have seen along the way, we had cases as early as March that would fit the criteria for MIS.C. So we will summarize here the 28 cases we've seen before the end of May. So all of these children met the CDC definition for MIS.C. Most of them also met the WHO definition. And the discrepancy really comes in the day of fever criteria and also the age between 19 versus 21. They represented a wide age range from newborn, right, 1 month old, all the way to 17 years old. There's a slight male predominance in our group. And what is significant in our population also from what's seen in New York and Philadelphia is there's a huge discrepancy in terms of underrepresented minorities. So 43% of the patients in this 28 patients were Hispanic and Latino, 18% were Black African American. Both of these groups represent about 9 to 12% in the population, in the general population of Massachusetts. They had about symptoms for about 5 days before coming to the hospital, and only about a third had known contact with somebody with COVID-19. What is remarkable is when we had antibodies tests up and running, 18 of 19 of these kids tested for antibody had positive IgG, mostly IgG, and some had positive IgM. And by PCR swab, about 61% had positive test. Similar to what's reported in other places, many of these kids come in quite sick. So 61% needed ICU admission, and most of those were for hypotension, right? So about a quarter of them needed inotropes. 42% needed some type of oxygen support, and BiPAP and CPAP was needed in about a quarter. I mean, most of them only needed for a brief period of time. Within a few days, they came off and went to room air. Invasive ventilation, nobody needed intubation. One trial had a tracheostomy at baseline and was mechanically ventilated during the admission, but nobody needed intubation in the process. In terms of specific clinical manifestation, so everybody had fever, as of course, is part of the definition for this condition. Majority of kids had gastrointestinal symptoms, so nausea, vomiting, diarrhea, and hypotension or shock is a major one here. So about half of these kids had hypotension up on admission. So conjunctivitis that looked very much like what we see for Kawasaki disease, this limbo-sparing feature of conjunctivitis. Skin rash we see about a third, and it's very non-specific. This is the type of the viral exanthum that we see commonly in almost any virus, nothing specific about this virus. And many of these are just by historic as well. By the time they come in, the rash is gone. The rash is stripped there for a day and it's not there anymore. We see some strawberry tongue, it's a little bit of lip swelling, we've seen some. And lymphadenopathy was not a common finding as compared to what we see in Kawasaki disease. In terms of laboratory studies, so inflammatory markers are very common, right? That's elevated. And we test a number of them just to make sure we don't miss any, right? So we have procalcitonin, CRP, and also ferritin. They're elevated in the majority of these patients. LDH is also in 74%. Set rate tend not to be so useful. About a third of these kids do not have an elevated set rate in our scale. Looking at the CBC, so even though they're very inflamed, their white count is not particularly high. In fact, they have more of a lymphopenia picture, like what's described in the adults with COVID-19 as well. 75% had a relative lymphopenia. platelets tend to be on the lower side also, so thrombocytopenia at about 64%. They have evidence of coagulopathy quite commonly, so high D-dimer is seen in most of these patients. Some have high fibrinogen, and some have high PT and PTT as well. What is also really important is to test cardiac enzymes and also BNP upfront. So half of these kids have elevated BNP when they first come in, and some have elevated troponin as well. AST is high in about half, and then renal failure is it's not as common. We saw about 2 cases out of the 28 patients. So before I sort of make form comparison to Kawasaki disease, I just wanted to give you a reminder of this pediatric condition, this type of vasculitis we see in pediatrics that's not so common in adults. Typically, we see this in age between 2 to 5 in the pediatric setting, right? So you have 5 things we look for in addition for persistent fever for at least 5 days. They have a conjunctival injection, right? Type of conjunctivitis that's limbo sparing. So looking at there's a white rim around the eye there. They have mucocutaneous inflammation, including strawberry tongue and red lips and cracked lips. They can have a viral exanthem that can be any type of rash, swelling of hands and feet, and also lymphadenopathy of the cervical lymph nodes, typically on one side greater than 1.5 centimeters. So some of these are truly seen in this MIS.C associated with COVID-19. What is really concerning about this condition is the coronary story, right? In Kawasaki disease, the only way you can prove that somebody has Kawasaki disease is the development of coronary aneurysm. Because most of the other symptoms by themselves are simply non-specific, right? It takes the whole pattern. And in fact, we treat Kawasaki disease is because we want to avoid the coronary issues. So in MIS.C, what we see is out of our cohort, 7% had coronary dilation, defined by Z-score between 2 to 2.5 on measuring the coronary vessels. And 14%, 4 of these kids had coronary aneurysms with Z-score greater than 2.5. So exactly what we worry about for Kawasaki disease. In addition to that, what we don't see in Kawasaki disease is the degree of cardiac dysfunction. So 39% of these kids had ventricular dysfunction, and many of these had hypotension as well, which is different from the respiratory story. If you look at their X-ray, the majority of them have normal X-ray. So about 25% had enough evidence for radiologists to cause some type of pneumonia. Out of the kids that have coronary abnormalities, not all of them had the full feature of Kawasaki disease. So some of them have maybe 3 features, actually including one that has no features at all, right? So the development of this coronary problem may or may not have anything to do, right, in terms of whether to present with a Kawasaki-like picture or not. And most of these kids also, the age range is also very different, right? We think about Kawasaki disease in kids between age 2 to 5. So you can see a whole sort of wide range of ages here. They are usually antibody positive. And if you look at their ejection fraction, many of them had ejection fraction below the 55% threshold. So now let's compare MIS.C versus Kawasaki disease, because Boston Children's is a major center for Kawasaki disease. We see easily 10 cases a month for Kawasaki disease here. And so what we did is we took 40 cases of Kawasaki disease from the past year before March of this year. So 40 consecutive cases between May of 2019 and March of this year. So before the COVID era. And just make some comparison in terms of both clinical findings, also laboratory findings. So the first thing, panel A is looking at age range. So you can see in Kawasaki disease, the peak comes in age 2, right? And by the time they hit age 8 or 9, we don't see Kawasaki disease anymore. Versus the MIS.C with COVID-19 is really an even distribution across all age range. Although the characteristic can be quite similar. Looking at individual Kawasaki disease criteria, we're looking for diagnosis of Kawasaki disease. It certainly is more common in Kawasaki disease, right? Because we're using these criteria to diagnose KD. But there's a variation between somewhere between 20 to 50% that these kids can have one or more of these features. If you count the number of criteria on panel C down here, so in Kawasaki disease, we usually want 4 or 5 of criteria to say this is complete Kawasaki. And every now and then we have kids have just 2 or 3 criteria, but still have a syndrome that look very much like Kawasaki that we call incomplete Kawasaki disease. So the range for Kawasaki disease is usually between 2 to 5 criteria. In MIS.C in comparison, there are about half the kids have 0 or 1 criteria, right? So not all of them have the KD-like picture, although some do have it, right? There are a few of these kids do have 3 criteria or even 4 criteria that looks almost identical to Kawasaki disease. And we also make some comparison of the Z-score of the coronary vessels here, just to note that we do see the same type of coronary abnormalities we see in Kawasaki disease with MIS.C. fortunately, we haven't seen a giant aneurysm yet in our cohort. As I mentioned before, one of the major differences between MIS-C and KD is the cardiac function. So in Kawasaki disease, the main concern is really the coronaries. It's not so common to see ventricular dysfunction, whereas it's extraordinarily common to see a ventricular dysfunction in MIS-C. So looking at the graphs down here, both by ejection fraction percentage and also by the Z-score, about half the kids in MIS-C has some degree of ventricular dysfunction that is not seen in Kawasaki disease. If we look at the labs, so Kawasaki disease is a very inflamed condition, right? So it's the white blood cell count is very, very high typically. We don't see that so much for MIS-C. It's looking at the lymphopenia is really a striking difference comparing MIS-C to Kawasaki disease. Kawasaki disease, you don't really see much of a change in lymphocyte. You see a lot more neutrophils, which you don't see also in MIS-C. And another classic finding in the laboratory of Kawasaki disease is high platelets. So most of these kids, especially a week after the illness, their platelets can go to 700 or even close to 1 million. And in contrast, in MIS-C, many of these kids actually have low platelet count as part of their viral illness. Looking at inflammatory markers is not as helpful. So CRP is pretty much the same for MIS-C and KD. Set rate's a little bit higher in Kawasaki disease, and also AST is a little bit higher in MIS-C. So there are discrepancies in terms of laboratory findings and also in their clinical spectrum. Although there are some similarities, especially in terms of the cardiac findings of the coronary abnormalities. So looking at the immunologic features of MIS-C, so we're rheumatology, we like to sort of look at the different parts of the immune system as well and to see if this reflects any other condition that we work with. One of the remarkable things is the degree of lymphopenia, just across really all different lymphocytes. So CD4 T cells, CD8 T cells, NK cells even, and to a less extent B cells are all low in kids with MIS-C. What we don't have is comparison with sort of kids with COVID-19 that don't have MIS-C, right? The milder infection that would sort of put this in the context of is this specific to this condition or is this a general picture of SARS-CoV-2 infection? Most of them have normal immunoglobulins at baseline, so not a ton of immunodeficiency, at least B-cell immunodeficiency in these children. And the majority of them also have normal titers to PCV and also tetanus. We did cytokine panels for about 20 of these kids, and what is notable is that they have a moderate rise of IL-6 that's beyond the normal level, and they have a quite striking high level of IL-10 that's definitely abnormal. And this pattern is also described in these severe cases in adult as well in terms of COVID-19. So thinking about the cytokine issue, right, there's a lot of discussion about this being a cytokine storm, right? So when you have lots of cytokine being activated, lots of inflammation that goes in cycles, activating macrophages and T cells in a cycle. And one parallel we see is something called macrophage activation syndrome. In rheumatology, we see this typically associated with a condition called systemic juvenile idiopathic arthritis, although it can also be triggered by different types of infections, most commonly EBV virus, but also many different viruses as well. One of the similarities between MIS-C and macrophage activation syndrome is the degree of T cell activation reflected by soluble IL-2 receptor level or soluble CD25. So the level for many of these kids are really at the level we see for MAS associated with both systemic JIA and also for infection. Although the degree of ferritinemia is not so striking compared to these other conditions. So ferritin tends to be elevated in many of these kids, but they're not as high into that tens of thousands of range we're used to seeing for macrophage activation syndrome. There are other differences. So C-reactive protein, which reflect more of an IL-6-like pathway, it's much higher in MIS-C compared to MAS, both systemic JIA and also for infections related. Versus set rate is more or less comparable to these other conditions. In terms of the liver involvement, inflammation in liver tends to be a little bit higher with other infections compared to MIS-C. So I'll tell you a few things we learned along the way for the past month in kids with this condition, and then I'll briefly go over what we've done for treatment. So what we learned is that MIS-C can affect children of all ages, right? Very different from Kawasaki disease, where if somebody's over the age of 9 or 10, we don't really think about Kawasaki disease so much anymore. But this truly can affect the entire age range. Most kids with this condition have detectable antibodies to SARS-CoV-2 by the time they present, which hints at this perhaps is a later finding of the condition. Although this is not yet proven, right? It's association. It's hard to know whether the antibody is a causative factor here. There's some debate about, is this a antibody-dependent enhancement process, although there's no clear evidence to point to that yet. So no, we really don't know what's causing this late immunologic presentation of SARS-CoV-2. There's disproportionate impact on the represented minorities groups that's seen across the United States and also in the UK. Beware of the cardiac complications. We see a lot more sort of cardiac complications compared to pulmonary complications in this phase of the disease. Hypotension and shock are quite common initial presentation. We do see some Kawasaki features, right? But we don't need to use that as the diagnostic feature in the sense that you can have coronary aneurysms even without these Kawasaki disease features. And the laboratory findings that are common are lymphopenia, thrombocytopenia, elevated inflammatory markers, and as well as elevated D-dimers. So how do we treat this? So I think the short answer is we still don't quite know. We're doing our best to learn along the way, right? This is certainly a huge collaboration between many teams in hospitals, starting from the initial providers in the emergency room, the ICU doctors, general pediatric groups, cardiology, hematology, infectious disease, and our rheumatology teams to come up with a treatment plan, both for the infection piece and also for the inflammation piece of the puzzle. So of the 28 patients we had so far, 17 had an ICU stay at some point during their admission, and 11 did not require ICU stay. This is updated toward the end of May, but everyone has gone home from the first 28 patients and nobody died in this initial cohort. We only had 2 more patients since then that fit the criteria. So we really have seen the wave of infection or wave of MIS-C coming down since the end of May. It's important to know that some of these kids do not need treatment, even though we're defining this by a case definition from these organizations. It's probably a whole spectrum from very mild disease to very severe disease. 6 of these kids came in, they became afebrile within 24 hours. Their labs start trending in the right direction without treatment. And so we did not give them any additional anti-inflammatory medications, and they did well on their own without any additional treatment. For the kids with hypotension and cardiac ventricular dysfunction, also the Kawasaki-like presentation, they were concerned about the coronaries. They almost all got IVIG because that's a standard of care for Kawasaki disease. And in the more severe cases, especially with cardiac dysfunction, we also give them steroids up front. So the most common combination we have used is methylprednisolone IV and also IVIG. In a couple of cases where steroids was contraindicated, we have used anakinra and sometimes also added on to steroids. And this is IL-1 receptor antagonist that we have lots of experience with in macrophage activation syndrome and other inflammatory conditions. And Dr. Sharma talked a little bit about remdesivir. So a quarter of these children receive remdesivir, and many of them, because when they first come in, it's hard to rule out other infections. So many got a course or more of different antibiotics. But I would say the majority of the cases in this cohort receive IVIG as treatment, and they've done quite well so far. This is the strategy used by other groups as well. I think that based on the summary provided, it seems like there's more than 80% of cases receive IVIG so far from what we learned. And so what do we do for follow-up? And this is something that's also a work in progress. How do we, what happens afterward, after leave the hospital? So we're really worried to the point that we're bringing them back pretty frequently in terms of blood draw and repeat echoes, just to make sure things have smoothed out before we let them go. So far the follow-up is primarily by rheumatology and cardiology. We have a special attending and nurse coverage just to deal with the volume of calls from this past month. So we help to taper steroids, taper other medicines. And one thing to mention also, many of these kids got anticoagulants, so whether it's aspirin or Lovenox during the hospital course. We keep in touch with family about their clinical status. We repeat labs at least a couple times in the first week, and then maybe one more time in a couple weeks just to make sure things are in the right direction. And an EKG and also echocardiograms just to make sure the coronary arteries are staying the same or improved. And so far that's been the case. So all the cases where we see abnormalities, the majority have resolved in terms of the coronary abnormalities, and the ones that are a little more advanced seem to be very stable as well. So these are all the things we learned so far, and certainly, as I said before, this is a living document that we're still learning a lot about, and hopefully we don't see so many more cases in the future. Thank you.
Thank you, Dr. Lee. Thank you so much for that extensive experience at Boston Children's, and really insightful. I think we can quickly move on to the next presentation. I will invite my colleague, Dr. Judith Owens, and she is the Director of Sleep Medicine at Boston Children's Hospital, Professor of Neurology at Harvard Medical School. She's an international authority on pediatric sleep and has published over 175 original research. she's actually involved in working in some of the sleep issues, particularly in Chinese group during COVID-19 pandemic. And I think during this pandemic, one of the thing is kids are at home, they don't have a regular schedule. So we just were interested as a sleep team that are we prepared for this new pandemic of sleep disorders in pediatrics and how we can handle? And I think there are not enough sleep physicians. I think pediatrician will be dealing with that. So some insight into the sleep problem and how to handle that, Judy. Judy, you need to unmute yourself.
Yep. Now can you hear me? Good, good, good. So thank you very much. Just get back to, there we go. So in contrast to the wonderful presentations that have been given so far, mine is not going to be very data driven. Because there isn't a lot of data out there. And I just reviewed what was on PubMed Central today in terms of the relationship between COVID-19 and sleep in children. And there's very little out there. I do anticipate that there's going to be an explosion in data that's going to be published in the next 3 to 6 months. But right now it's more speculative. And so I'm going to focus my presentation really on some of the opportunities and challenges that we as pediatric sleep medicine specialists and those of us who treat children with sleep issues who may, many of whom have been exposed to either COVID-19 or more commonly to the societal repercussions of COVID-19. And I know you have another presentation after mine that's going to talk more about the mental health issues, which I think are really important. So I want to cover the very little that we know about the impact of COVID-19 on children's sleep, and then really focus on the challenges and opportunities in going forward as the pandemic, at least in Massachusetts, seems to be slowing quite significantly, although obviously it's picking up in many other states around the country, and how that we envision this may change pediatric sleep medicine, I think in many ways for the better. And so there's a lot of opportunities that I think arise from this situation. So as Dr. Katwa mentioned, this is a study that is currently under review in the Journal of Clinical Sleep Medicine. And it's a study of preschoolers during the COVID-19 outbreak in China. And I think China thus far is a very rich source of data about what happens on many different levels during the stay-at-home, home confinement aspect of COVID-19. So this was a survey of almost 1,700 caregivers of 4 to 6-year-olds from 11 preschools in the Guizhou province, compared to a similar sample of preschoolers. Many of the same schools were represented back in 2018. So it was as close to a pre-post survey as we could get. And interestingly enough, the caregivers reported significantly later bedtimes and wake times, which was perhaps not unexpected, with different sleep patterns. So these children were sleeping longer at night and napping less during the day. But perhaps the thing that surprised us most was, in comparison to the 2018 sample, caregivers actually reported fewer sleep disturbances in the confined sample. And there were certain variables that predicted reduced sleep disturbances, including sleeping in a separate bed or room from the parents, having a regular diet, less use of electronic devices, a more harmonious family atmosphere as defined by the caregivers, and increased parent-child communications. All of these variables were associated with less sleep disturbances in the COVID-19 sample. So the implication here, which I think is quite interesting, is that enforced home confinement may be associated with changes in sleep patterns, particularly in younger children, but not necessarily with increased sleep problems, given certain conditions and certain kinds of parenting behaviors and family environments. So I think that gives us a little bit of optimism in terms of how this may affect children. Another study, the only other study that I found that really was relevant to children and sleep was a study of 33 hospitals, again in China, and they looked specifically at mental health services for children during the period of enforced home confinement from COVID-19. And as you might expect, overall, the outpatient services decreased by 50%, but that was somewhat compensated for by initiation of online visits. And what I would point out here is that at least in one pediatric hospital that they surveyed, 22% of the patients who were presenting for outpatient services reported insomnia. So there is a sense that at least in certain groups of children, and we don't know yet whether that's age dependent, what other kinds of variables are in play, but there may be more reports of insomnia in pediatric patients or not. So I think that it'll be very interesting to see how this plays out. So I wanted to talk a bit about the kinds of challenges that we have faced in our own institution, and I think are quite similar, at least in pediatric sleep services across the country in the United States. And so some of the challenges that relate specifically to the sleep lab, of course, include infection control issues, and how do you maintain social distancing with 6 feet apart in the sleep lab, and personal protective equipment, what is appropriate, how best to allocate what in some cases is not abundant resources, particularly for the techs who are working with the patients during the night. You heard a very elegant description of what kind of testing is available, but you know what we face in terms of reopening our sleep lab are reduced availability of tests, the logistics. When do we test? You know, it should be by guidelines 48 hours or less before a procedure like a sleep study. And what are the indications for testing? Is it only for symptomatic patients? And there's increasing reports of false negatives for these tests, particularly in asymptomatic patients. And right now, we're not testing parents, we're only testing patients. So it becomes a bit of a conundrum in terms of what are the best procedures in terms of safety for both our staff and our patients and families. What is the impact of reduced availability for sleep studies on non-urgent or non-essential clinical care? And in particular, I think at many institutions, including our own, adenotonsillectomy is now considered, in most cases, an elective procedure. So Many of our sleep studies were done in patients who were being considered for adenotonsillectomy, and how does that affect triaging and selection of patients and scheduling of patients. And on the one hand, much longer wait times and delayed cares in many patients as resources are limited and may be diverted to more urgent cases is certainly a consideration. But on the other hand, there may be a drop in sleep study requests for routine studies. And when and how will that volume pick up, and how do we handle that? And how do we handle the backlog of cases that we have already? You know, in our particular facility, we have a 3 to 4 month wait list for patients to get a sleep study. And right now we have over 300 patients on our list that haven't even been scheduled for sleep study. So this is a big problem in terms of triaging and access to care. And also the cost of running sleep studies, if we have to maintain social distancing, this may require a one-to-one tech to patient ratio, which makes it all that much more challenging to provide access. On the other hand, I think there are some real opportunities, how we can integrate remote monitoring devices in clinical care, including the use of commercial apps and the expansion of home testing in children. This has been a big issue for a number of years now, and I think as a field, we've been somewhat divided on the utility and feasibility and validity of home testing in children. But this experience with limited resources for an extended period of time may change our view on whether home testing is an appropriate diagnostic mechanism, and for whom, for which patients that's the case. We've also looked more towards auto PAP versus a titration study because of the risks involved in any aerosolization of potentially of the virus, with things like tracheostomy studies and titration, PAP titration, positive airway pressures titration studies. So what groups do we assign to auto titration at home, which is something that we really, again, have somewhat resisted as a group in the past. We also need to explore further the use of ancillary healthcare providers. And I really hate that term. They're just as important as we are, but nurse practitioners and RNs and respiratory techs. This may be a time to re-argue having a special regulations for accreditation of labs that study children. Because right now in the United States, there are no specific mandates for labs in terms of conducting, interpreting, scoring pediatric studies. And I think this is also an opportunity to involve our QI teams in terms of helping us decide what metrics to look at, how do we measure success, how do we assess what is going right and what isn't. And that's where QI teams can be really instrumental in helping us answer those questions. In terms of challenges for clinical services, specifically for pediatric sleep, so again, this impact of the pandemic on lifestyle and sleep of our patients and families, which may lead to delayed sleep onset, poor sleep hygiene, irregular sleep-wake schedules, insomnia. And we need to have a better sense in the future of whether these sleep problems will increase and persist, and if so, are we ready to meet the demand in terms of our availability of clinical services? You know, we in Massachusetts have a mandate from the state government that insurance companies will currently pay for telemedicine visits. And that is something that has dramatically transformed our clinical practice in the last 3 months. It's really astounding to me. And for the most part, I think it has gone really well, and families really appreciate the ability to connect with their healthcare providers without making the trip into the hospital, particularly at a time where they're concerned about their safety and their child's safety. And so how we're going to be able to negotiate in the future to continue these virtual visits and how we're going to triage that. Obviously, there are some patients that are going to need to be seen in person, but others that do perfectly well with telemedicine. And I think we also need to understand and figure out how to update our medical records to reflect the kind of data that we can collect during virtual visits. And so the opportunity is very much reflective of the challenges in that telemedicine is a rapidly evolving entity in clinical medicine now under COVID-19. And there are opportunities in terms of retaining the feasibility and utility of these telemedicine visits. And developing new ways of doing virtual examinations, technologies which may even further reduce the need for in-person visits in the future. I just want to touch on clinical research. I have been involved in this for a very long time, and it's pretty much come to a halt right now, and particularly in terms of any kind of clinical research that involves our sleep lab. Because is this a non-essential service or a time-sensitive service? And should clinical research take a back seat, especially if there are very long wait times for clinical patients to come into the sleep lab? And when is it safe and feasible to start? We do have a lot of guidance from our hospital research administration team in terms of reintroducing clinical research projects into the lab and into the clinic. But this also may require modifications to recruitment strategies, and it already has done so in terms of using entities like Facebook to recruit families rather than being able to do in-person recruitment, and whether funding resources will change in the future regarding clinical services. And I think it's important to consider that there's going to be a whole host of new research questions. As I mentioned earlier, the impact of COVID-19 on sleep parameters in children and adolescents. We have a group that's come together that is developing a research protocol to look at the impact of remote and both synchronous and asynchronous learning environments on sleep, and as a result on mental health parameters. So as you probably well know, many school districts in the country, including colleges, are either going to go to total remote learning come the fall, or some combination of remote and in-person learning. And I think this is a very interesting opportunity to look at these different learning paradigms and approaches, not only on sleep, but on a whole host of different outcomes. And what is the impact?
We have we have another session starting. So
yep. Okay. And so I'll just move ahead. Challenges in medical education, training sleep fellows, clinical precepting, how flexible is ACGME going to be in terms of sleep training, and how do we mentor trainees during the pandemic? But it also allows us to develop new teaching methods. And then what is the impact of moving to virtual professional meetings, as many of us are experiencing? Most of our professional meetings now have moved to virtual platforms. And how does that impact the future of sleep training? And then finally, what are the short-term and long-term aspects, impacts on staff of all these really profound changes in practice related to COVID-19? And how are we going to handle a second wave if that almost inevitably comes? And so will there be permanent changes, particularly in safety measures in clinical practice? So I will stop there and thank you for your attention.
Thank you, Judy. I think we'll wrap up quickly. For the last talk, Dr. Carolyn Sell, she's a psychologist at Boston Children's Hospital, and she's actually involved in the Massachusetts Governor's Office in advocating for the patients and the parents about challenges during this COVID quarantine. Carolyn.
All right. Hello, everyone, and thank you for the opportunity to speak with you all this evening. I will keep my comments brief and focused, but am happy to talk with you about the psychological effect of COVID-19 and what physicians can do. As some of you all may have heard in the news, at the beginning of the pandemic, there was a large spike in emergency room admissions for both youth and adults for psychiatric reasons. And so there was a concern that throughout the pandemic that there were going to be a lot of mental health concerns. We've certainly seen mental health concerns in children and teens, and I'll talk about those in a minute. But there's also this concern, and our speaker on sleep mentioned this as well, about this idea of like a shadow pandemic, that actually after the pandemic is over, that the mental health sequelae are likely to continue for some time. And so I think that'll be something for us all to watch out for. And I also just included some statistics as far as how many Americans are saying that the coronavirus crisis is negatively impacting their mental health, and how many are reaching out in various ways for services, which is certainly something that we've seen as mental health care providers in our hospital as well. As with some previous studies, there is not a ton out there so far. I did find 2 rapid reviewed articles, which I thought were worthy of sharing with you all. The first comes from Italy, and it's a very large web-based survey. And they were asking about a very broad set of mental health outcomes of the COVID-19 pandemic and lockdown together. And what they found was post-traumatic stress symptoms were the most common. This is again in adults. Followed by anxiety and high perceived stress and adjustment difficulties, and also with some significant depression and some insomnia, although less. And we certainly are seeing some of these characteristics show up in children as well. And then a review of 24 studies on the psychological impact of quarantine. This is not specific to COVID-19, but rather quarantines in the past for other pandemics. So this looked at 24 studies and found that some similar findings as far as some post-traumatic stress symptoms and also confusion and anger, which I'll speak about in a moment. And so again, this is in adults. And they found some interesting things as far as what made mental health symptoms worse. And, you know, some are to be expected, right? If the quarantine is longer, for example, or there are inadequate supplies, of course, that would be, you know, logically make the psychological impact worse. But interestingly, inadequate information was quite associated with it. And that's heartening for us because we've done a lot of things as a hospital to try to provide information to our patients and families, both on an individualized basis and also through webcasts, through newsletters, and all of these sorts of outreach efforts. So that is encouraging. But some research is showing these again, long-lasting effects. What do we see in children? So some of what I'm about to say is somewhat anecdotal, but I've spent the majority of my professional time since the start of the pandemic talking with children and families who are at elevated risk for COVID-19 and for developing complications. So this is some of what I have seen in that. A lot of grief reactions, and so those could include denial, those could include kind of like bargaining type reactions, as well as anger. We certainly see a lot of irritability and anger in kids, and some of these things can often look sort of quote unquote behavioral in nature, like kids are just being difficult to be difficult, when in fact this may be, you know, a true impact of some of the more traumatic aspects of quarantine for kids, because, you know, similar to adults, right? Kids are feeling lonely, kids are feeling confused, kids are wondering when this is going to be over, you know, all of these types of things. And particularly, perhaps unsurprisingly, but very worth keeping in mind, I think, you know, we're especially seeing these issues amongst those who've already had mental health concerns identified. And so as physicians, I think being sure to kind of, you know, screen those people or ask those people about mental health concerns would be important. In terms of talking with children about the pandemic, so this is something that I was asked to speak about, and that, you know, I think it's a very important topic that parents often ask questions about, but also important for physicians. The biggest piece of advice that I would give is to meet children where they are. So some children will want a ton of information and some will want much less information. And, you know, the ideal, according to the research, is to provide about as much as they want within reasonable limits. And so, you know, but within that, you know, using realistic but non-threatening language with kids, you know, it's really important to be realistic because, you know, we're building trust, of course, in all these interactions, and don't want to say it's going to be over by this time, or this is going to be fine if we're not sure, or that type of thing. So that's also very important. Often to get kids talking, giving examples of these are some common reactions I've seen in other kids, you know, is this something that's happened for you? Can also be very useful. And really focusing on, you know, there's a lot of this that we can't control. And I think for kids, as well as for adults, that's really hard. And so really focusing on, you know, what can we do to stay safe and well? What is in our control? And some of that may look like infection control, and some of that may look like taking care of our own mental health during the crisis, which is also really important. So what can physicians do? So in our experience at Children's, parents have a ton of questions. And this is true of parents of medically vulnerable children, certainly, but also parents in general. And these are all very reasonable and very specific things that parents are typically asking about, right? Is it safe to go to a barbecue? What about a camp? What about, you know, and so much of this is really about individual circumstances, both from a health perspective and from you know, the perspective of what activity they're engaging in, that it does seem as though a lot of those conversations really need to be, you know, with someone on the care team who is trusted by that family, really taking the time to talk through the individual case. But certainly we have also tried, again, those larger education efforts as well through webinars and such. I would also encourage to refer for therapy, including virtual therapy, if it seems as though that's needed. And I'm going to talk about screeners for emotional distress associated with the pandemic in a moment. But something really important to note is that in the mental health world, you know, because we don't touch our patients, we have been a bit ahead of the curve in terms of virtual visits, and now we're providing even more. And so those resources are out there for children and teens as well. But, you know, really important things being validating both parents and children's emotional reactions. I was asked to focus on children, but I think it's also really important to say that parents, if anything, may be the more and the most stressed, and sort of giving parents permission to talk about that. And I think those of us who are parents probably identify with that. And then remembering to screen for some of these things that I list below, including some that may not be quite as intuitive, such as, you know, behavioral changes, and making sure to ask about somatic symptoms that could be associated with increased anxiety and things like that, since we know that anxiety more often shows up in that way in children. And so I want to conclude with sharing a couple of tools and resources with you. So there are two already validated assessment scales out there. They're both very brief, like 5 questions long, and available for free online if you just look up the title. And one of them is quite good for kids, I would say, ages maybe 8 to 10 and up, the coronavirus anxiety scale. It's a couple of brief questions asking about things like anxiety and symptoms of depression associated with the pandemic. And then there's the pandemic stress index, which it could be a good tool, I think, for parents. It asks a lot more, instead of asking specifically about mental health symptoms, it asks more about what are you doing in response to the pandemic? How have you been impacted and in what areas of life? And so can provide a nice springboard for kind of conversation as to how families and children have been impacted, I think. So I would encourage, considering using these scales. And also I list below that there are a lot of great resources out there on the internet for families as far as, sample daily schedules for kids and all sorts of things that can be useful for mental health. But this website is also quite a good one that's actually was developed. The resources were developed by Harvard Medical School students largely, with input from some of us as well, and provide for elementary and middle school age children some nice examples of that non-threatening language in terms of how to talk with them about the pandemic.
Awesome. Thank you. Thank you, everybody. We have a couple of questions that we'll quickly wrap after this. Then we have a question for you. Ask about how many days after exposure do you get the positive PCR? And should it be used with other swabs?
I think I lost you.
Umakant, he was asking how many days after the exposure do you get the PCR and a positive PCR?
Yes, so usually our expectation is that it takes a minimum of 48 hours after exposure, but really ideally 5 to 7 days after exposure, you would expect to see, that would be sort of the ideal window when you would see a peak of a positive PCR. So if you're testing earlier than that, you're likely to have a false negative.
Right, do you combine that with other tests as well to get a better yield, or is it redundant?
No, if you're testing within the window that you would expect to see the highest viral load, then the nasopharyngeal swab, a single swab, is actually very highly sensitive and reliable, and we don't usually recommend any kind of combined testing at that point.
Thank you. There was a question, not a clinical question, but did pediatric ICU doctors were kind of switched to adult ICU doctors? Did it happen?
Well, so I can speak to Massachusetts. We had a lot of pediatric intensive care units that were actually taken over by adult patients, not at Boston Children's Hospital specifically, but in some of the combined centers like Boston Medical Center and Massachusetts General Hospital. And in those cases, it was primarily adult providers that were taking care of those patients, but there were some pediatric ICU providers that were deployed in those areas. And certainly in places like New York, they saw a much greater degree of that role.
One question for Dr. Lee. The demographics show for 36% white, 43% Hispanic, 18% Black and African American. What about Asian Americans? Anything there? Or how come this seemed like much more in white population in this pediatric population versus adult population?
So we had 2 out of the 28 patients were Asian. So I think that's on par with the general demographic. I think in terms of the demographic breakdown, I think it's a complex set of data set, right? There's a lot that goes into it, whether socioeconomics, in terms of living arrangement. We don't really have a sort of a clear explanation yet. But what is seen is that's seen over and over in other part of the U.S. as well, and also in London, where it seems like the minorities seem to be more affected by this condition.
Some of the questions were answered in the chat box. Dr. Suresh Reddy wants to give a vote of thanks, and then we proceed to the next seminar because they are waiting. The panelists were waiting. Thank you, everybody.
Thanks, everybody.
Okay.
Thank you so much. Thank you, Ravi and Umakant, for organizing this wonderful talk. Thank you all the speakers, and you can hang around and answer some of the questions in the chat room. That is totally fine. And special thanks to Dr. Tanvi Sharma and Dr. Lee, Dr. Owens, Dr. Snell. I used to work at Beth Israel and Brigham for 15 years. And I walked go to the Starbucks right across that Harvard Medical School building. Matkant has this virtual picture, feels home there. Thank you so much. And we used to have $5 tickets to the Fenway Stadium because Beth Israel was is still the official. So we get a $5 tickets. We used to go there. Thank you so much. Thank you all. And the next team, Dr. Saras.
Thank you so much. Thanks, Tony. Thanks,
thank you all.
Thanks, Dr. Lee.
Bye, thank you.
Thank you. Bye.
Thank you all the panelists for being here and providing such an excellent education to our AAPI members. We really appreciate you being here.
Thank you, Ravi. Thank you. Thank you, Seema. Thank you.
Thank you, Makant. It's so great to see so many speakers from my hometown, Boston.
I know, the Boston Symphony.
Thank you, everybody. Thank you, all the speakers.